Hello and welcome to the University of Washington, Washington Area Cardiometabolic Project Echo Session 2. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington Diabetes Institute. We're so excited to continue this Echo program. Today, we're excited to have Dr. Earl Hirsch from our own University of Washington Diabetes Institute. He's a national and international expert in diabetes. He will be giving the second lecture on individualizing glycemic goals. And as well, our physician associate, Dove Rainbow from Tillamook, Oregon County FQHC will be presenting an interesting metabolic case today. So now I'm going to ask Earl to briefly introduce himself. Go ahead, Earl.
Sure. Thanks, Nicole. It's great to be here. I was with you once before. I guess that was a couple of years ago. I've been here at UW now. I am now in year number 35. I have a lot of research interests all over the map, both in type 1, type 2, and atypical diabetes. And it's great to be here.
Thank you. And now, Dr. Lorena Wright, can you introduce yourself?
Hello, everybody. I am Lorena Wright. I am an adult endocrinologist, and I spend most of my time at the Diabetes Institute. I'm also the director of the Latinx Diabetes Clinic within the Diabetes Institute. I'm happy to be here. Thank you.
Thank you. And now, Dr. Savitha Subramanian.
Hi, everyone. Thank you, Nicole. I am one of the faculty here at the University of Washington. I am a lipidologist and diabetologist. I run our advanced lipid disorders clinic here. Lipids and diabetes are my two big hats, and happy to be here.
Thank you, Savitha. But without further ado, we're going to go ahead and let Earl start his didactic. So go ahead, take it away, Earl.
Thank you, Nicole. Part of my responsibilities, I actually got back a little over a week ago from a diabetes meeting in Madrid. And the unfortunate part about that is I came home with COVID. So I feel fine, but I occasionally get these little coughs. And if I do, please understand it is all related to that. I'm delighted to talk about this topic, which is of great interest to me. These are my disclosures for those who are interested. We do a lot of research from industry, the NIH, the Breakthrough T1D, which used to be called JDRF. We're actually doing 3 studies right now with that group. And these are the objectives, explaining A1C goals and targets based on characteristics of the patient, identify renal and cardiac risk in patient assessment for medication optimization, and discuss individual treatment choices based on patient characteristics. So we don't have polling here, but we'll just do this sort of thinking through this since I can't see your hands. How does one measure glycemia? Is it fasting glucose, frequent home glucose monitoring, A1C, or CGM? And as it turns out, at one time or another, all of these were correct. But we're sort of getting away from some of these now. But there are still some fingerprints of our past in our regulatory system. For example, with the FDA to get a new drug approved from the Food and Drug Administration, one of the outcomes is fasting glucose. And that comes from 40 or 50 years ago. Home blood glucose monitoring became very popular in the 80s and 90s, as did hemoglobin A1C. But certainly now we get so much more information from continuous glucose monitoring. But all of these are actually correct, or at one time in our history were correct. Now, this was a very important study that we actually participated in 2007. It was funded by the American Diabetes Association, and we put on some of the original Medtronic continuous glucose monitors on patients with type 1 diabetes, type 2 diabetes, and we also took patients, or subjects, I should say, without diabetes from around the world, and we looked at what their hemoglobin A1C level was based on their average glucose from the CGM. And as you can see, with an A1C of 7, the average is 154. With an A1C of 9, it's 212, and so forth. And to this day, Many, if not most, of the commercial labs in the United States still use this study to inform both clinicians and patients what the glucose level was for that given A1C. The problem is in table 2 of the paper, which not a lot of people paid attention to, are these 95% confidence intervals of the average A1C for this population. And I need to point out, and this is a really important point, these people had no kidney disease, they had no liver disease, they had no anemia, they had no hemoglobinopathy. And in fact, even if they had no anemia, but they had a high reticulocyte count, we kicked them out of the study. So this is about as perfect of a population as you can go. And when you look at this, what you see is an A1C of 7 means that the actual average glucose could be anywhere between 123 and 185. And this was done for 3 days over 3 consecutive months. What this means, if you look at this, is somebody with an A1C of 7 could have an average glucose of 180, while someone with an A1C of 9 could have an average glucose of 175. What that means is that for an individual, you could have a higher average glucose at an A1C of 7 than an A1C of 9. And a lot of people don't know that. You can compare hemoglobin A1C levels in the same person if it goes up or down, but you can't compare it between two different people because they mean two different things. So one can't compare the A1C levels between two people. Each A1C comprises a wide mean glucose range, and this does not take away from using an A1C in a clinical trial, or if you are looking at the A1C in your population of patients in your clinic, that's all fine. Some people are going to read high, some people are going to read low. Now, obviously, if you are a nephrologist and you have a lot of CKD and dialysis patients, your A1Cs are going to be low. In fact, I would even say they may be worthless. But nevertheless, the A1Cs in clinical trials obviously are fine. But what this means is using A1C by itself to make a decision if you're going to increase somebody's medication intensity, decrease it, or stop it, you need to know what the glucose levels are because the A1C by itself is not going to tell you. Really important point. This is another study done by our friends Roy Beck and Rich Bergenstahl, and this is really important. And in fact, literally yesterday, another paper came out showing the exact same thing. Two real big points from this study. Point number one is that at any of A1C, here we'll look at an A1C of 8, you can have widely divergent mean glucose on the CGM. So you could have an A1C of 8 and have a glucose of 120 or 130. Somebody else with an A1C of 8 could have an average glucose of 210 or 220. Widely divergent. That's point number one. Point number two is that the African Americans on average are 0.4 to 0.5% higher at any average glucose than a white individual. Let me repeat that. We're using A1C to make the diagnosis of diabetes, to tell somebody it is safe to get pregnant, to grade us as physicians, yet if you're African American, you're going to read 0.4 to 0.5% higher. And not only that, but literally yesterday, another study came out showing that number may be closer to 0.6. So race and ethnicity actually does have an impact on one's A1C. And that could be due to the lifespan of the red blood cell or a genetic component, which I am interested in my research. How well or how quickly does somebody glycate proteins, whether it's hemoglobin, retina, or glomerulus. So what everybody needs to understand now is this concept of GMI, glucose management indicator. It's all it is it's a mathematical equation that takes the average from the CGM and tells you on average what the estimated A1C is. What happened was the US FDA said you can't use the terminology estimated A1C, so the term GMI came out instead. So it's a metric calculated from a formula from this same population of over 500 people of mean glucose, and you can see it on all the downloads. It's on all the CGM apps. The patients have it if they know where to look for it. And a lot of patients, they see it on their app on their phone, they don't know what it is. Well, this is what it is. And what my research has been interested in is looking at the discordance between the GMI and the actual A1C from the lab. That turns out to be very important. And here you can see this comes from my group here in Seattle. We had 641 people, mostly type 1s. They were on their CGM on average for 25 days. The A1Cs were measured within 30 days of the CGM download. And look what we found. This is just a mess. That, pick any glucose level, take 150, for example, and you can see dramatic differences in what that A1C is at any given glucose level. And we actually worked this out with our statistician. The A1C and the GMI, or the estimated A1C, only were right on top of each other 11% of the time. 50% of the time, they were 0.5% off. What does that mean? Well, what that means is if you have a GMI or an estimated A1C of 7, the actual A1C from the lab is going to be above 7.5 or below 6.5. Furthermore, 22% of the time it was a point off. So if the GMI is 7.0, 22% of the time the hemoglobin A1C from the lab is going to be above 8 or below 6. Like they didn't even have diabetes if they're not on any medication. This is the reason why, and we didn't have this data back in 2009, but this is the reason why I have never been for the use of hemoglobin A1C to make the diagnosis of diabetes. It simply makes no sense of mine. We know that the A1Cs with CKD, with estimated GFRs under 60, are going to be falsely low. We know that. But the point is, I just want to make the fundamental point, using A1C as your only metric for what you should do with the treatment of the diabetes doesn't make a lot of sense. Now, here is a study, and this was I believe this one was a type 2 study. There's a type 1 and type 2 study. They showed the exact same things. And that is, on average, a 70% time and range on hemoglobin A1C, a 70% time and range on the CGM, on average, is an A1C of 7%. But when you look at a general clinic population, there is all type of scatter. And we see this in all diabetes. It doesn't matter the type. Now, this is really interesting. This is an older population. This is a study that population we are studying here in Seattle that was a type 1 population that the study ended in 1993, called the Diabetes Control and Complications Trial. But these individuals continue to be followed. We are now in year number 41. And as they get older, they get more comorbidities, more chronic anemias, whether it's from CKD or rheumatoid arthritis. All kinds of things happen to these people as they get older. And here, what happened was there were 765 of these people, 60 years of age. A1C was 7.8. They put a professional Libre on these people. This is a CGM where the patients couldn't see the data while they were wearing it. They were wearing it for almost 12 days. And I want you to look at the scatter in this population with all of these comorbidities. And let's just look at this for a moment. Yes, on average, a time in range on the CGM of 70% is an A1C of 7 on average. But that doesn't tell the story at all when you look at all the scatter. You see all of these people that are below the line, that are above the line. I mean, here's an individual with a time in range of about 35%. Very, very low time in range, yet the A1C is 5.9. And here's another person with a time in range of 83, 84% with an A1C of 11%, with a time in range well above 80, which makes no sense. But this is the problem when you're looking at the discordance between glucose and A1C, especially as one gets older. I do not consider 59.9 years of age old, but this is what you see in a population, which is the reason why we believe FDA sooner than later is going to be using these metrics in looking at new drug applications. And I need to point out, in a clinical trial, if you're looking at a new GLP-1 to see how it lowers glucose for labeling for a new drug, in a clinical trial, all of this discordance wipes out. But that doesn't help the patient that you're seeing in your clinic if you're trying to decide if you should start that patient on basal insulin. So A1C works for a population, but not individual patients in assessing glycemic control. I hope I made that point loud and clear. Now let's talk about complications for a second. Macrovascular complications is multifactorial. I'm not going to go through each of these except to point out to my friend Dr. Subramanian on the bottom right are the lipids. And I want to point out in an article that came out last week in JAMA, heart disease mortality is still number one and it has not changed. But there are a lot of things. Some things you can change, some things you cannot. By the same token, microvascular complications is, at least from a mechanistic point of view, a bit simpler. Genetics, glucose, and blood pressure. That's it, as far as we know, and this slide has not changed in many years. So, management of type 2 diabetes in 2024. We look at the efficacy of glucose lowering. I have A1C here. That's okay if we're looking at individuals, because in an individual, if the A1C comes down, the glucose is coming down. But we also need to look at safety, specifically hypoglycemia prevention. And where this leads to is cardiovascular and renal disease prevention. This renal disease prevention, we have our first trial that came out earlier this year. I guess it was actually late last year, the FLOAT trial looking at semaglutide as a primary endpoint with a renal outcome. And actually, the GLP-1 receptor agonists do improve renal outcomes and preventing dialysis and transplant. But the history for this is really interesting. Going back to 2008, the FDA came out and said that we need to establish the safety of a new anti-diabetic therapy to treat type 2 diabetes. Sponsors, that is the pharmaceutical industry, should demonstrate that the therapy will not result in an unacceptable increase in cardiovascular risk. Now, the history of this is really interesting. A cardiologist and his statistician at the Cleveland Clinic, Steve Nissen, he came out with this New England Journal paper suggesting that the drug rosiglitazone actually resulted in an increase in cardiovascular mortality. As it turns out, that probably wasn't correct. But the point was, instead of just using glucose to make a decision if a diabetes drug should come on the market, we should look at cardiovascular and renal outcomes. Specifically, at the very least, they shouldn't have an impact on cardiovascular outcomes, and ideally they would show a benefit. So over the years, there have been many, many cardiovascular outcome trials. This is an old slide. I couldn't find a newer one because there have been many more. And that brings us to which drug to use in which situation. We have all of these targets. When I was a medical student, all we had was insulin and sulfonylureas, which worked on the beta cell on the far left side of the screen. But now we have drugs that impact all of these different targets. And I want to start with the SGLT2 inhibitors. It's hard for me to believe that these drugs are now a decade old. These are not new drugs anymore, but they're not as used as much as they should be given the data we have. In a database that I'll be showing you at the end of the discussion, I can tell you that when you look at the SGLT2 inhibitors and you also look at the GLP-1 receptor agonists in a commercial database looking at 79 million people, what I can tell you is now this was actually 2022 and 2023, I can tell you that between 33 and 41% of this commercially insured population are on an SGLT2 inhibitor, a GLP-1 receptor agonist, or both. And so even though these drugs are the SGLT2 inhibitors that work by causing glycosuria in the kidney, even though it's a decade old, these drugs, because of all this positive data coming out, I think we are finally starting to see the use that they should have given the non-glycemic effects of these drugs. So I'm not going to go through individual trials, but I do want to show you here, looking at these different meta-analyses. This top one in those individuals with atherosclerotic cardiovascular disease, there's 5 trials here, and you see this 11% risk reduction with this hazard ratio of 0.89. That was statistically significant, of course, but you don't see a significant decrease in risk in this meta-analysis for those without atherosclerotic cardiovascular disease. Importantly, this meta-analysis is looking at major adverse cardiac events, MACE. And when we look at just MACE, the SGLT2 inhibitors, what the data shows, and I think pretty clearly, just looking at this endpoint, where these drugs have their impact are in those individuals who have known atherosclerotic cardiovascular disease. On the other hand, if we look at cardiovascular death as our endpoint, and we looked at the pooled endpoint, here we see this 15% risk reduction. We do see a significant risk reduction favoring the SGLT2 inhibitors. Now, if we look at hospitalization for heart failure, yet a third endpoint. Now we look at it by atherosclerotic cardiovascular disease on top, without atherosclerotic cardiovascular disease for the 3 studies on the bottom. What's interesting here is that for heart failure, whether they have known atherosclerotic heart disease or not, you have this tremendous impact on hospitalization for heart failure. Tremendous impact, independent if they have known heart disease or atherosclerosis or not. Now we look at the renal outcomes. Now, the renal outcomes are important because some of these studies do not have the renal outcome as the primary endpoint, but with or without atherosclerotic cardiovascular disease, these drugs have clearly shown to improve renal endpoints. And not only that, but these drugs have also been shown to improve the renal endpoints for those individuals without diabetes. So those are the SGLT2 inhibitors. The GLP-1 receptor agonists have 4 different places they work. They work at the beta cell, the alpha cell. They work in the brain. They work in the gut by reducing the gastric emptying. I am working with a colleague here in Seattle by the name of Mike Schwartz. We are specifically interested in how all of these drugs work on the brain. We won't be getting into that. Instead, I just want to get to the bottom line. We showed about SGLT2 inhibitors with major adverse cardiac events. Do we see a similar signal with the GLP-1 receptor agonist? And the answer is yes. We see this 14% risk reduction, odds ratio of 0.86. It's statistically significant for these drugs. And this signal comes up over and over in the clinical trials. What about cardiovascular death? We look at cardiovascular death, and again, it's not as strong as what we saw before, but it is statistically significant with this hazard ratio of 0.88, this 12% risk reduction of cardiovascular death with these drugs from the various clinical trials. And now we look at renal endpoints. Again, the flow study is not included here. These are all secondary endpoints. But once again, we see this significant renal benefit of 17% with these drugs. These drugs clearly improve renal outcomes in type 2 diabetes. The type 1 diabetes trials are now ongoing for both of these drugs, for both of these classes. And I just want to point out the flow trial, because here the investigators did use semaglutide with a primary renal outcome. No surprise, you can see on D, you can see death from cardiovascular disease was lower with semaglutide. It was a 29% risk reduction. But look at D on the right side. the slope, the reduction of the decline in GFR of the semaglutide group on the top compared to placebo. These drugs are clearly renal protective. And as of right now, as we speak, semaglutide does not have an FDA indication for renal disease, but we know that that is on the way. So, key components. Now, this is important, and this is really important, especially this slide here, because we are, as physicians, often we are so focused on the drugs, but type 2 diabetes in particular is so much more complicated than just the drugs. And in particular, the Diabetes Self-Management Education Program. This comes directly from the ADA standards of care. Every individual needs to be offered this, especially individuals with newly diagnosed diabetes, because we are talking about an entire lifestyle. Facilitating medication and adherence should be specifically considered when selecting glucose-lowering medications. These ADA standards of care initially came out in 1989. It was 2.5 pages. We had 2 drugs to treat diabetes. None of this was possible. Now we can deal with adherence, whether we're dealing with pills versus shots, whether we're dealing with cost. There are all kinds of things we can do to improve patient adherence. Point number 3, the GLP-1 receptor agonists and SGLT2 inhibitors for cardiovascular or renal benefit for people with type 2 diabetes should now be considered independently of baseline or target A1C. You have somebody with an eGFR of 55 and 500 milligrams of albuminuria, they need to be on one of these drugs. Somebody who's had a TIA, they need to be on at least one of these drugs, even if their time in range and A1C is controlled. It doesn't matter. GLP-1 receptor agonists are the first line injectable therapy for type 2 diabetes. It's not insulin anymore. And that last bullet point on this slide is not new for 2024. That has been the case based on the data and based on the glucose lowering ability of the GLP-1 receptor agonist and the weight loss of the GLP-1 receptor agonist. That's been the case for 4 or 5 years. So let's look at this a little bit more closely. Healthy lifestyle behavior, going through self-management, education, and support, social determinants of health need to be understood with all of our patients. But once we get through that, we need to look at what drugs do we use if they're not at target or if they have known cardiac disease or known renal disease. Well, if they have known atherosclerotic cardiovascular disease or if they have a very high risk, and this is the part that's a bit controversial. High risk meaning if they're above the age of 55 with 2 or more additional risk factors. Well, then they belong in this part of the algorithm. And what that means is if they have atherosclerotic cardiovascular disease or they're at high risk, they should receive a GLP-1 receptor agonist or an SGLT2 inhibitor based on the data. I showed you the meta-analyses. And if the A1C is then above target, you could either add the other drug or potentially add a thiazolidinedione. We don't talk much about that, but that's especially relevant potentially for people with fatty liver disease, MASH. On the other hand, for somebody who you see with known heart failure, the SGLT2 inhibitors are clearly the way to go based on the data I showed you. And then finally, for those with CKD, for those with albuminuria, we're going to start with an SGLT2 inhibitor. But I have to say, I think the data from the FLOW trial is going to push this. So it says GLP-1 receptor agonist with proven CVD benefit if the SGLT2 inhibitor is not tolerated. I think we're going to see semaglutide here in the next iteration of this algorithm based on the data we saw. And I will tell you there's some interesting data that is now popping up showing even greater benefit to the kidneys with using both classes of drugs, an SGLT2 inhibitor and a GLP-1 receptor agonist. At the bottom of the slide, you say, if additional cardiorenal risk reduction or glycemic lowering is needed, well, then you need to go on to the next side, and you need to do what you need to do for glycemic control. And this is something that we have really been focused on for decades, although we didn't have the drugs that we do now. For people who don't have atherosclerotic cardiovascular disease, for people who don't have renal disease, you can actually start here with the goal of a more glucocentric goal of getting the glucose levels into target, whether you're using CGM or you are using A1C. My suggestion to everybody is that when you're seeing a patient for the first time, you need to do at least one CGM so you know if that patient has a discordant A1C or not. Whether you do a professional CGM, whether they buy it over the counter now, which they can do, or whether you prescribe it for one time, because otherwise you don't know what that A1C means. And I do that, even if they just wear it once, if they're not going to wear it again. You notice on the left side of the slide, they look at higher efficacy in looking at the glycemic goals, and you see very high for dulaglutide, semaglutide, tirzepatide, insulin, and then these combination GLP-1 basal insulin combinations we use. And then we see high drugs. This is the first time we see metformin, sulfonylureas, thiazolidinediones. There are many of my colleagues around the United States and around the world who don't understand why we start metformin in everybody. I don't take quite that stance. I think metformin is quite reasonable in the right situation, especially the younger people, because as we have seen from the diabetes prevention program, metformin works extremely well in that population. And then, of course, we get into the issues of the obesity population over here, where these individuals, we have all of these different tools, and I'm not going to go into any deep discussion about them, but I do want to always remember that metabolic surgery is still appropriate for many people. And you can see at the bottom, as far as the GLP-1 receptor agonists and other drugs for weight loss, our drugs now, semaglutide and tirzepatide, have the highest efficacy for weight loss. So, nevertheless, if the A1Cs are still above target, DS, the education, referral, always referral to the support to see if there are problems there. Always consider the CGM so you can look to see where the problems are worse. Identify and address the social determinants of health that impact achievement of goals. This is such a big topic. People can't get their insulin. They're embarrassed about their insulin, whatever it is. I do want to point out that we still, many of these patients still require multiple injections. A few weeks ago, the first insulin pump for type 2 diabetes was FDA approved. There will likely be 3 more within the next year. And the other thing I want to just mention, something that is probably not going to come up the rest of the day, but there was some very interesting data presented from a study called Catalyst. Everybody has these patients with type 2 diabetes we can't control. And we don't know why their diabetes is so hard to control. Well, as it turns out, a quarter of that difficult to control population flunk their dexamethasone suppression tests. They essentially have subclinical Cushing's disease. And there is now a drug being evaluated to see if that drug being used for that population is the best way to treat in a precision type of way. But we did not realize until really earlier this year that cortisol was such a important role in the pathogenesis of type 2 diabetes. So when we talk about the technology, we have level A evidence now for real-time CGM, intermittently scanned, which is the Libre 2, although we now have the Libre 3, which is real-time. I mean, the data is very clear for people who take insulin. The data is also very clear for people only on basal insulin. So Medicare covers any insulin at all. CGM is now covered. And even for people who can't get CGM covered by their insurance, if they can afford it, as of about 3 weeks ago, there are now 2 over-the-counter CGM devices available. And like I said, just a few weeks ago, OTC. Now, What about CGM in primary care? The way we do CGM in our clinic doesn't really matter, but this was a really interesting study. And what was found is that clinicians located more than 40 miles away from the nearest endocrinologist's office were more likely to have prescribed CGM. I mean, we can all speculate why, that if they were closer, they were being seen by the endocrinologist, I guess. Clinicians who served more Medicare patients reported favorable attitudes toward future prescribing and higher confidence using CGM to manage diabetes. And I think the reason there is that the Medicare had been covering CGM for multiple injections in both type 1 and type 2, and these clinicians became very comfortable with CGM. And the most needed resources to support CGM in primary care were consultation on insurance issues, how to deal with that, how to navigate the insurance, and of course, CGM training for the patients. Now, what's going through everybody's mind right now and what's going through my mind is this cost effective? Is all this therapy that we're talking about for these medications cost effective? And this was a study that came out last year. Newer anti-diabetes drugs as second line are the cost-effective option from type 2 diabetes from the cost effectiveness perspective, especially the SGLT2 inhibitors. Now, there should be an asterisk here because the asterisk of this analysis is that these are people who meet the ADA criteria of they have known atherosclerotic disease, they're at high risk, or they have known renal disease. Nevertheless, this data was based on the published cardiovascular outcome trials. Thus, given the expense of the cardiovascular disease in the United States, these agents are cost effective for those patients with known cardiovascular disease. Obviously, that doesn't mean everybody can afford the agents, even though they may be cost effective for society. It's a long, complex issue I'm very interested in, and I hope many of you were able to see the video on YouTube yesterday of the Senate hearing with the CEO of Novo Nordisk that makes semaglutide. Very fascinating. So, thinking about glycemic targets, I think you also have to think about, do they have or do they not have cardiovascular disease or diabetic kidney disease? Many other factors, age, duration of diabetes, what's their life expectancy, important comorbidities, patient preferences, resource and support systems. But realize if you are only using A1C, you may be thinking about this wrong because the A1C may not be giving you an actual viewpoint of what's going on with their blood sugars. So although A1C is our most traditional target and the target for most adults are less than 7%, I would suggest that the time and range on the CGM of above 70% or the GMI below 7% are reasonable metrics for you to use here in 2024. Finally, this went online a couple weeks ago. We presented this data in this large database of 6,000 people where we had the A1C data and the CGM data. NIT is no insulin therapy, BIT is basal insulin therapy, PIT is prandial insulin therapy. And as you can see, the A1Cs in these individuals, now this is a retrospective trial, it is a trial, but when an A1C goes from 8.6 to 7.5, that glucose level is going down, in this case with an A1C of 1.1%. We also showed less hospitalizations, less ER visits. And the point is, this CGM is a powerful tool. And what this is really suggesting, we think about CGM as a tool for glucose monitoring. I would suggest to you it's an incredibly important tool for glucose lowering because those NIT patients were all lifestyle changes, that bottom line. So even though we look at it as a glucose monitoring tool, especially for hypoglycemia prevention and people on insulin, I think I would be much stronger about this being a lifestyle management tool. And so I would conclude for individuals but not populations, A1C as your glycemic metric can result in problems, mistakes, One should perform at least one CGM, as I mentioned, to see if there is discordance or not. The etiology of macrovascular complications is more complex than what we see in the eye and the kidney. Lifestyle is still the cornerstone of type 2 diabetes, as we saw in that last slide with those individuals not on insulin. Data has emerged that for heart failure, chronic kidney disease, atherosclerotic cardiovascular disease, that the SGLT2 inhibitors and the GLP-1 receptor agonists should be used early in the therapy if they have those comorbidities, and the glycemic targets need to be individualized. When hypoglycemia agents are required, the fundamental goal is as low of an A1C or as high of a time in range as possible without disabling hypoglycemia. And with that, I thank you very much for your attention.
Thank you so much, Earl. That was a great talk and a lot of information. There was one question in the chat. We're going to be very brief because we want to get on to the case, but can you just comment very briefly on CGM and time in range correlating with microvascular and macrovascular complications and the emerging data on that?
Yeah, so most of the data on that for both the small and large vessel is coming from the big data analysis. We are looking at some of this, we are looking at cross sections in time. And when you look at cross sections in time, we do see that in these cross sections of time, people with the lower time and ranges have more retinopathy, nephropathy, and cardiovascular disease. With that being said, we do have emerging data looking at GMIs from 7-point glucose profiles from the DCCT. In the DCCT, as this is just one example of one study, quarterly they did 7-point fingerstick glucose levels. And you can take those 7 points, take an average, convert that to a GMI, and showing that those GMIs over time do associate with microvascular disease. My final comment about this is that when you look at the GMI and you look at the A1C together as a ratio, and this is where my research is right now, what we are seeing is looking at them together as opposed to individually does a better job of looking at complications than either alone. It's very, very interesting what we are seeing.
Thank you so much for that information. And I'm going to ask Jessica to share Dove's slide. And Dove Rainbow, go ahead and introduce yourself and start our case today.
So this patient is a 34-year-old woman with BMI of about 53 who came to see me for weight management. She's not totally yo-yo dieted, but she has multiple times lost like 10 to 15 pounds in the past, regained each time. Over the past 4 years, she's gained about 50 pounds. Recent labs show she developed prediabetes, elevated LDL. She's working on lifestyle changes, meeting with behavioral health, doing food tracking, calorie restriction. She wants to do a trial of GLP-1, can't afford it, insurance is denying it. We ended up starting her, she's already taking metformin and Wellbutrin. We ended up starting her on phentermine for weight management, and she's down about 9 pounds in 3 weeks with a half tablet of the full dose, the 37.5 milligrams. So the things that I'm bumping into are inability to obtain the GLP-1, which I think would be fitting for her due to financial barrier and insufficient insurance coverage. 9 pounds in 3 weeks is more rapid weight loss than I am typically looking for. It'll probably slow down, but I tend to see people yo-yo if it happens that quickly. So I'm wondering whether to adjust the phentermine dose, decrease it for her. And then if it is effective, guidelines recommend, or at least what I've seen, they recommend like 3 to 6 months max on phentermine. I've seen some people do it for longer than that. I'm wondering how long you guys recommend continuing with the phentermine as long as it's working for her and her blood pressure is still looking good. Family history, the main thing was just heart disease, maternal heart disease. She doesn't really have a lot of other barriers that I could discern, like transportation is fine. She has food access. Oh, there we go. So high cholesterol, diabetes, heart problems in her mom, and then obesity in siblings. And you guys can see her exam data, BMI 53, blood pressure is like pre-hypertensive, Her A1C was 6.3%. Her random glucose was 95. And now I'm wondering if I should be having her checking blood sugars at home because the A1C could be like 1 point up or 1 point down. I don't know. But her other labs looked good. And we haven't done a ton of talking about her diet because she's working on that with dietitian and behavioral health. So we're focusing more on the medication management side of things. So this is all I had in my last chart notes as far as dietary stuff. Oh, and the last barrier that I hadn't talked about, untreated severe sleep apnea. She has a BiPAP that was prescribed, but she doesn't wear it because the power on it is too strong, and she doesn't have a sleep medicine specialist that she's working with. And then she does have some joint pain and eats to distract herself from pain.
Thank you so much for that great summary, Dove. With the ECHO project, what we do then is open it up for clarifying questions. And so any clarifying questions in the chat, I'm going to start with one. So does she have any dark purple lines or stria on her abdomen or thighs? Does she have any proximal muscle weakness on her exam? Or does she report problems brushing her hair or standing from a chair? Or does she report any new onset of easy bruising?
I haven't done abdominal exams, so I could do that next time she's in and look for a stray. She doesn't have any of the proximal muscle weakness, and she doesn't have easy bruising.
And the reason I ask those questions is not everyone we need to do a secondary evaluation for weight gain, but we do think about Cushing's syndrome. And clinically, in this case, I would say that it's probably ruled out by those 3 lack of positives, although we can always do it in the future if we're not seeing her meet her weight loss goals. Any other clarifying questions? Otherwise, I'm going to let Savitha take it away and sort of summarize the case and come up with some great points about the case that can help you, hopefully support this patient.
Okay, thanks, Nicole. So we're going to go a little bit fast because we will run out of time real quick. So very quick summary. Thank you for that very nice presentation, Dove. So we have a 34-year-old woman who's been struggling with her weight. BMI is about 53 right now. 54. She has prediabetes. She has severe obstructive sleep apnea and some other, and she's struggling with anxiety and depression. She's got Cigna as her health insurance, and laboratory testing we've already reviewed with nothing really that stands out except for her A1C being 6.3, and you can see her med list there, and she's on phentermine. So what was presented was, this woman has barriers, coverage for some of the weight loss medications, especially the GLP-1 receptor agonists, which is unfortunately not unique to this individual. There's financial barriers, and then there seems to be untreated severe sleep apnea, which is not, so she's not on treatment for that. And she's also eating to distract from pain. So questions that have been posed are, should the dose of phentermine be adjusted due to rapidity of weight loss? How long do we continue with phentermine? And how can we get GLP-1 receptor agonists covered for weight loss? BMI classification, just to remind everyone, class 1 obesity is BMI of 30 to less than 35. Class 2 is 35 to less than 40, and greater than 40, she falls in class 3 obesity. And she has serious weight issues related to her weight, which includes the prediabetes now and her obstructive sleep apnea, which I think was described as severe. So this slide has information that I borrowed from my lovely colleague, Dr. Montour, who I think is on the call. Thank you for joining, Laura. To prevent diabetes with weight loss, you need to lose 10% of your body weight to prevent diabetes. And then there's a whole bunch of other metabolic parameters I've mentioned here. Dyslipidemia is about 5 to 15% of body weight that you have to lose to improve lipids, hypertension, and steatotic liver disease, and other conditions associated with obesity like arthritis, asthma, sleep apnea. You need to lose anywhere from 5 to 10% approximately to get a desired benefit. This woman has come to Dove asking for help with her weight. I just want to point out here, weight loss, weight management is tough for me as a clinician. It's really important to communicate clearly with our patients when we provide obesity care, but doing so is not always easy. So opening a discussion is important. The good thing is here she is interested in weight loss, but just as a reminder for some communication tips in the obesity field, they talk about the 5 A's as an approach to talking. So ask permission to address weight, address the patient's desired weight loss goal and reasons for wanting to lose weight, advise about the treatments that match the patient's goal and are likely to produce desired results, agree on the goals for weight loss, lifestyle, and behavior modification, and help or assist the patient by creating these goals. So using this approach while talking to our patients can help improve the success of obesity treatments and also help better motivate our patients. Here are the different aspects of obesity management, and I've mentioned this. There's eating patterns, or what we call diet. My dietitian friends do not like using the word diet. They call it die with a T. So eating patterns are a preferred term. Physical activity, behavior modification, and then medications or surgical. Again, as a reminder, so when Dove mentioned in the case presentation, this individual has been successful in losing weight by using various calorie tracking methods. So helping her continue with that and adding protein to every meal, and making sure that they drink a lot of water and staying hydrated is important. So eating patterns, physical activity. If she's not very physically active, it's important to bring it up and ask what their baseline is. If they have joint issues and they're not really moving, maybe starting very slow, 10 minutes a day or 15 minutes a day, or sending them to physical therapy, I know is what one of the things that Dr. Montour in our weight loss clinic likes to do, just to get them stronger so they can get moving eventually. And looking at the barriers to incorporating some kind of physical activity. I want to point out here that what we call diet or eating patterns are more weight loss and calorie restriction helps more with weight loss than physical activity, but that doesn't mean that we don't enable or encourage our patients to become physically active. And behavior modification, which was mentioned that she was working with someone, it's really important to address any psychosocial stresses. Are there any stresses going on at home? Their work stress, life stress? But I do think an important part in this woman is to address her sleep issues, because when you don't sleep well, you're just constantly hungry through the day, and so you keep munching, and so weight gain can be related to the unaddressed or poor sleep issues, because that's just the way the hormones work. So very important to address the sleep issues. And the specific questions were regarding the medication management, so we'll get to that here. Make sure you look at the med list and ensure that there's no meds that promote weight gain. I don't think there are any on her med list, but it's important to look at it. You start pharmacotherapy when the BMI is over 27 and there's comorbidities, and she fits the category here. And all the anti-obesity medications that are available on the market can result in weight reduction by about 5% or body weight or more. Metformin is something she's already on. So in my experience, this is not a weight loss agent. Using it for prediabetes is completely acceptable. A lot of the weight loss you may get with metformin, it's very minimal, 3% or less. That's if you're lucky. It may be related to the GI side effects. There may be some appetite suppression, but I don't know that that's a strong, I would not call metformin a weight loss medication, but you can use it for other indications in her case. So now getting to phentermine. Phentermine is a stimulant. It suppresses appetite. It is the cheapest one that's available in the US, and so it's also the most prescribed because it's easily available. It is FDA approved for short term. And what that means is a few weeks. And by few weeks means it's under 3 months. It is not FDA approved for longer term use. If you're using it longer term, it is off label. And it also depends on the state. If you live in a state where there's laws prohibiting long-term use, you cannot use it. Washington State is not one of those. So here you can use it longer term. Correct me if I'm wrong, Laura. But it does not have addiction potential. The one thing is it is a stimulant, so you have to monitor blood pressure and pulse once a month, so they have to come in. Or I'd be curious to hear other people's thoughts, but I usually, if they have a blood pressure machine at home, they can measure at home if they don't want to come in. But it may be best that they come in and at least have a nurse visit to get their blood pressure checked in primary care setting. You want to be cautious in people who already have palpitations, heart failure, coronary disease. These are not situations where this medication should be used, and she needs to be on reliable contraception to be on phentermine, because this controlled substance is category X for. And there is a prescription version of phentermine along with topiramate, which is approved for use by the FDA. However, it is branded. It may not be covered. The way to prescribe is written over there, but there is a way to get it for cash, and I will show you in the slide with the costs in a couple of slides. But before I move to the next slide, I will stop and see if Dr. Montour has anything to add on phentermine.
No, like you said, Washington, we can use it longer than short term, but documenting off-label use.
Yeah, so that's the key. So thank you, Laura. So you have to make sure you counsel the patient, and you need to make sure you put it in the chart. My next slide is on the GLP-1 receptor agonists. So these are the most potent anti-obesity medications that we have now. Phentermine can give you about 5% body weight loss. These are more potent, 15%, 5 to 15%, depending on the agent. The drugs that are available are listed there. One thing to point out is that, so semaglutide branded Ozempic and tirzepatide branded Mounjaro are used for diabetes only. So if you send for Ozempic or Mounjaro for weight loss and they don't have diabetes, it will get rejected. So the branding for semaglutide and tirzepatide for weight loss are Wegovy or Zepbound. Now, unfortunately, most insurances do not have weight loss as a benefit. Some do, but not many commercial insurances do not. It's almost impossible to get them with Medicare and Medicaid unless certain situations, which we'll talk about. So these are meds which help suppress appetite, increase satiety in people without diabetes. Because they decrease food intake, they decrease gastric emptying, and so you eat less, and so you lose weight. There's also other benefits, including cardiovascular benefits from an atherosclerotic standpoint and improvement. There's probably a heart failure benefit, possibly, I should say, and a kidney benefit that you heard from in people with diabetes that Dr. Hirsch mentioned. So there's a lot of benefits from these agents, even in people who do not have diabetes. Potency-wise, again, this is a very busy picture, but I thought it was important to show it. Phentermine is over here, about 5 to 10% body weight loss, and semaglutide is up to 15%, and tirzepatide, the dual incretin, is up to 20%. So very significant weight loss, so potency-wise, if you look at these agents. So the preferred ones, if you're able to get them, are the GLP-1 receptor agonists these days. And if you're interested in a good review on management of obesity in primary care, this is a really excellent article. I would refer you to look at that one. So cost. In both Washington and Oregon, if you're paying cash, phentermine is about $8. You can get the combination phentermine topiramate for about $100 through the company's program. That website link will get you right where you need to go. With GLP-1, as I said, it's very tough to get it. If the insurance does not have weight benefit, it's just not covered. So what I like to do, and I'm pretty sure this is what Dr. Montour in the weight loss clinic also does, is you put a lot of the responsibility on the patient. If they're able to, they can call the insurance company and see if it's covered. They can go to the drug website and put their information in, and there's that way to that's another way to have the patient do some of the work. Now, I do want to get on my soapbox and make sure I mention this. Compounded versions of these drugs are a big no-no. They are not recommended. Make sure your patient is not on these drugs. There are companies now that are actually advertising on television, like Henry Meds, and then there's another one. And interestingly, these compounded versions, these are for semaglutide. They're semaglutide salts. They are obtained from these chemical companies, and they're dissolved and made into a solution. The dosing may be incorrect, and there may be impurities. So please do not encourage your patients to go on compounded versions of these medications. Now, the most updated thing that I just heard about is Zepbound or tirzepatide. The company has now released it in vials. So this is straight out of the website for Lilly, which is the manufacturer for Zepbound. A 4-week supply of 2.5 milligrams Zepbound, single dose vial, is $399, $400. So they can actually, this is direct to consumer from the company. This is a self-pay channel, which removes third party. This is to prevent people going to compounding places. And then after the 2.5, they can go up to the 5, which is about $549. I'm not saying this is cheap by any means, but if there are people who want to get the medication this way, and 5 milligram dosing of tirzepatide can give you really significant weight loss. And for people who are really wanting to, use these medications and cannot get it through their insurance and they want to pay out of pocket, this is a new program the company has. Again, this is quite expensive, but there are people who may want to shell out the money to do this. So my understanding is, so I quickly looked, and I think Dr. Erhart and Dr. Montour also looked, and Cigna, depending on the plan, may have coverage for a GLP-1. However, a lot of times the coverage is, if it's a high deductible plan and they haven't met their deductible, I mean, it's the deductible is $5,000 or $6,000. They have to meet that deductible before they can get covered. So it's really important. So the patient has to really take some of the the responsibility on themselves if they really want to go on some of these medications. And with that, I will stop and open it up for. I didn't mention the CGM behavior modification tool, but on the pharmacotherapy, I'll stop and see if there's anybody wants to discuss anything. If Lorena has any thoughts, or Laura.
I just wanted to comment on duration. So we don't have any randomized control studies in phentermine itself. Glycemia was studied in the Concord trials for up to 2 years, and it was shown to be safe. We do have large retrospective database analyses for phentermine used over a year, and they actually showed better blood pressure control, I think because their weight was less. Laura, I was wondering if you could comment, how do you use phentermine in your practice?
If it's if that's what is working for the patient, and any obesity tool you want to evaluate after 12 weeks. And if they lose at least 5% on that tool, so for phentermine, I would continue it as long as they're getting a benefit. The challenge is that over time, as the body adapts, and we call it metabolic adaptation, hunger generally starts to rise, and we do start to see people starting to regain some weight, and we may need to layer other tools, but I generally will use phentermine, especially if it's working for a patient, as long as they're getting a benefit. But usually, because it's a controlled substance and it's off label, I'll see them every 3 to 4 times a year, generally.
So how do you counsel patients when you start them on GLP-1 receptor agonists for their eating patterns and eating habits? And have you seen patients where the GLP-1 stop working in quotes?
Yeah, so how I counsel my patients when I am planning to start in a GLP-1. So I told them about all the benefits, right? Because I really want them to have a very good attitude and to be, to stay on them. And I start with a very, very low dose and then gradually go up. I told them also that to prevent the nausea, to eat very, very slowly. And then that way, they might end up eating less. And so then that usually works pretty nice. I also tell them that if they have nausea, then to go back to the previous dose. When I'm concerned about nausea, for example, there was a question in the chat whether these medications are contraindicated in patients with gastroparesis. So when I feel that these medications are going to have significant benefits, then I might, even in patients with gastroparesis, I might start like a extremely low dose and very, very slow titration. And that was one question. And what was the other question, Savita?
Do you have anyone where it stops working, and what do you do then?
Oh, yes. So then when they say that whether it stopped working or is it going to stop working? Yeah, so, at some point, then they don't lose any more weight. They are able, to keep their weight stable. And I also tell them, that, for example, when we start a medication for high blood pressure, right? Like we don't expect that medication to, to be off that at some point, or we are not disappointed because we continue to need that medication, right? And so then I counsel the patients that way, like we are kind of treating a disease, so then we will need to continue treatment. The fact that we won't need to stop them, it doesn't necessarily mean it's a treatment failure. We are treating the disease.
Thank you, Lorena. Laura, do you have any specific eating or food tips that you give your patients when you start them on GLP-1s?
Part of my spiel for patients, I kind of go over the physiology. Our body always remembers our highest weight. So as we start losing weight, the body adapts to try to pull us back. And part of that, I tell the patient, is because metabolism generally slows down with weight loss. And metabolism is, basically the number of calories our body needs just to be us and live and function. And I tell them that the medicine that I'm prescribing, regardless of what it is, you've got great tools. They don't necessarily change or like speed up their metabolism. So I tell them that our lifestyle and specifically lean muscle is our most important tool to help support metabolism. So our muscles need adequate protein and our muscles need that activity. So that's kind of how I tie in, I guess, that piece in terms of its importance, but specifically what Savitha had put earlier in the slide, eating a protein every meal, every snack. I think tracking the food's very, very important because a lot of people just forget to eat on these things and they certainly don't get adequate protein and they lose muscle.
Thank you, Laura. And I think, we'll probably run out of time because I do have a slide on the newest over-the-counter CGMs, which can be used as behavior modification for someone. But again, this is all expensive. Our patient already has financial barriers. Managing any cardiometabolic disease is not cheap, but these are all tools that can be used if possible. The Abbott Lingo and the Dexcom Stelo are the ones that are FDA cleared now. Stelo is available and it's a 15-day sensor. So 2 sensors cost about $100 if you buy it over the counter.
We're almost at time, so I just want to mention, remember metformin has up to a 1% or more A1C lowering, and so it's not fair, but if we hold the medication for 3 months for her, she'll probably meet the criteria for diabetes and then maybe have access to medications for weight loss plus diabetes management. So just that final thought of how we best support our patients. And thank you so much, Laura, Savitha, Lorena, for all your insight. Thank you, Earl, for that great thought about a new way of looking at dysglycemia and CGM to better support our patients. And I will just say this ends session 2 of the Diabetes Echo. Thank you.